150. Let's get started. There are two bills in this subcommittee. Chairman asked me to have a meeting to first make sure the members of the subcommittee had a chance to review this and to let anyone who's interested in the public have the opportunity to know that these are two bills that are under consideration. And so what I want to do is just let the subcommittee members look at them, hear from anybody now, and we hope to make a recommendation on what to do with these bills in the next full committee of public health. So we've got the two committees, the two bills that are in the subcommittee are Senate Bill 21, let's do Senate Bill 2152, which deals with the Department of Human Services and county DHS officials. We have Mr. Anderson here from DHS. Do you want to say anything about these bills, Mr. Anderson? Do you not have that authority now? And there's federal funds available to pay our county some money for the maintenance and upkeep of that space. Any members of the subcommittee have any questions for Mr. Anderson? Okay. If anybody has any thoughts about the bill, please get with me or any of the members of the subcommittee. It'll be early next week, public health, where we'll make a recommendation on this. Secondly, we have a bill, Senate Bill 2340, which extends the repealer on Harper Grace's law. I believe Senator Harkins offered that bill when we first put it in the law. Senator Harkins, you want to say anything about it?
Well, I think the last time I talked to folks at UMC, they were doing some studies. They had 10 patients enrolled in the program. I'm not sure what the status on the number of patients are today, but it was a surprise to Mr. Sansing as he was driving down the road that they were participating in the project when I first did the bill. But I talked to the doctor that was heading it up, and I think he had informed me that it surprised him just the impact that it had on the families that were participating in it. Obviously, our laws have changed with the medical cannabis dispensaries that are allowed now. These people can there's a lot more product that's available to families and they kind of do on their own. At least under this law, there was a component of a federal trial that went along with it. And so I would like to see it continue just to see what kind of research they come up with at UMC and see what comes of it. But I don't have any other comments. Thank you. Dr. Woodward. Yes, ma'am. If anybody else, whether with the medical center or any member of the public has any input on this bill or the other one, please let us know. And as I said, we hope to make a recommendation first meeting next week of the full committee. Anything from anybody else? Motion? Rise and report. Thank you.
Oh, there he is, look at that. I know they are. We'll wait 1 minute. Do what? No, no. You can read later. Okay, thank you, everybody. We're gonna call to order the subcommittee. I think it's called Subcommittee W. Oh, for Wiggins, right? That's what it is. Okay, Public Health Subcommittee W, we have two items on the agenda. Senate Bill 2145, Senate Bill 2240. And Chairman Bryan has referred this to these subcommittees. And has asked, he specifically asked to report. So this is a regular subcommittee and we will be voting on these bills. And we have a number of speakers. And I'm going to call up first Senate Bill 2145. But before I get to the speakers, this is the bill you may have seen to the committee members, what's known as 340B. And I will give a brief explanation, but I have a video because I've had people ask me, what is 340B? And so I thought this would be informative to the committee. It's fairly short, but understand that 340B is a federal designation for what we all know as our community hospitals in the state. And the ones that, generally speaking, treat uncompensated, the majority of the uncompensated care in the state of Mississippi. And so, so what Becky's handing out is a general description of the 340B program from, taken from both the federal program websites, and tells you what that is and why it's there. So you can read that. I won't quote it. You can read it on your own time. But I want to show this video first, and then we will go to our presenters. So let's go to the video. As they say, let's go to the video. Thank you. I think that's a good synopsis of that. And so you heard, well, oh, that's not mine. You heard what's deemed, 340B hospitals. And this bill, we're gonna have some presenters from some of those hospitals. If you look at your agenda, hospitals that I think you recognize from across the state. And for the presenters, I'm gonna ask you to please keep your comments to no more than 5 minutes. And the light will, whatever light is here, that'll be going off. So on your agenda, we're gonna go first to Greg Havard, CEO of George Regional Health System. Greg, there you are. Hey, Mr. Havard. You can either, whatever's comfortable for you, we have the microphones. You can either sit there and speak into it, or you can stand. And I know this room is small, but there's a lot going on today, so.
Yeah. Testing, can you hear me?
Yeah.
My name is Greg Havard. I'm the CEO of Georgia Regional Health System in Southeast Mississippi. I'm also the committee chairman for the 340B Committee for the Mississippi Rural Hospital Association. And,
Greg, pull that microphone closer to you.
okay. I appreciate you guys giving me a few minutes to talk to you. The video was great. It kind of put the 340B in a nutshell. The 340B came about in about 1992 with the Public Health Service Administration Act. And not long after that, HRSA, Health Resources and Services Administration, kind of oversees the program. In about 2010, HRSA expanded the program to allow us to do contract pharmacies with independent pharmacies in the community. So over the years, we've done that very well. It's been very helpful for the state, the citizens, and the rural hospitals. It means about $1.2 million to our small rural hospital in Southeast Mississippi. We've given out about a little over $2 million in discounts to residents that are vulnerable throughout our state. And we think this is a great program for all of us involved. About 20 to 25 other states have introduced legislation just like you have, Senator Wiggins, and some have been already implemented a year or so ago. So we look forward to it. We thank you for helping us with this, everybody here. And so we think it's a great project. There has been some questions about oversight through audits. I can assure you that we get audited by HRSA twice over the last 9 years. We passed those with flying colors. So without it being complicated by PBMs, the audit process is pretty simple, straightforward. We opt out of Medicaid, so Division of Medicaid in the state of Mississippi can get those rebates back through the 340B program, and we don't take those at the local level. Any questions?
What I'm gonna do for the members is if we can hear from each of the speakers, and then we'll discuss the bill, and then if the speakers will be here, they can answer. You can ask any questions of the presenters. Okay? Yeah.
That's right.
Yeah, right, yeah. Next, we'll have Terrence Shirley from the CEO of the Community Health Center Association of Mississippi. I think people are familiar with our community health centers. Mr. Shirley?
Thank you all for allowing me to take a few minutes of your time. And I'm glad that you're offered the opportunity for the community health centers to come and speak before you. The video did not mention community health centers at all, and I want to make sure that we give you a little background of what we do, why we do it, and what the real issues are with us and our concerns going forward. For those that may not know, community health centers are community-based organizations that's run by a local board. That local board must have, at least by law, 51% of that board composition must be patients of those organizations. We see people regardless of their ability to pay. We're also considered the largest primary care network in the state. Our funding sources are federal grants, Mississippi state grants with the Mississippi Quality Community Health Center Association funding, private insurance, Medicaid, Medicare, and other sources such as 340B. In 2022, to show you the volume that we see, we saw over 311,000 patients, generating more than 1 million patient visits. Our economic impact is roughly $200 million annually to those communities for which we serve. our payer mix. 31% of our patients are uninsured. 29% are on Medicaid. 16% are on Medicare. 5% are dual eligible, and 24% are private insurance. As the video stated, we must, by law, reinvest all of those resources that we receive in the 340B savings back into our operation. As the gentleman before me stated, we are audited, we are transparent, and we've always provided the data necessary to continue to participate in the 340B program. The savings not only assist uninsured and underinsured patients access their medicine, but they also have afforded most of our organizations the ability to expand our scope of services. And in some cases, this is how we keep our doors open. In 2022, our total revenues for the 21 federally qualified health centers in the state was just shy of $270 million. Of that, 340B revenues represented 16% or $43 million. So we reinvested back into our communities $43 million. I won't go into the patient savings that my predecessor did, but we had 4 patients to testify with the drugs that they received, and the drug savings that they were able to receive was $2,500 off of their bills. That goes a long way when you talk about the patients that we are serving. Our concern. Over the past decade, PBMs have implemented strategies for their benefit by diverting savings from the covered entities, the uninsured, the underinsured, and this is reducing our opportunity and their opportunities to take advantage of those savings. Drug manufacturer restrictions have restricted access for low-income patients to life-sustaining medications by prohibiting contract pharmacies from participating in the 340B program. They also have limited the number of companies where drugs can be purchased and reducing the formulary for those public goods. Why do I bring that up? We serve a patient population that's mostly rural, underinsured, uninsured, and extremely poor. If we're restricting those contract pharmacies, we have patients that cannot access those drugs. So we're here today supporting the bills before you, and we're here later to answer any questions you may have as relates to how it impacts the community.
Thank you, Mr. Shirley. Appreciate it. Next, we'll have Lisa Fertizzi, Executive Director of the Pharmacy at Singing River Hospital System. And for those that may not know, Singing River doesn't just cover Jackson County, it covers much of the coast, along with Memorial Hospital, which we have representatives from Memorial Hospital here as well. Lisa,
Thank you.
5 minutes.
Okay, I can do it. Thank you, Mr. Chairman, for the opportunity. My name is Lisa Fertizzi. I'm Executive Director.
Lisa, please pull the microphone, and there's people probably watching,
Okay.
and so it picks that up too.
We, as everyone understands, we provide health care to underserved patients in the southern part of the state. We rely on 340B savings to take care of these patients. We manufacture restrictions that are clearly in violation of the federal mandate are preventing us from being able to take care of these patients. Our contract pharmacy business, since manufacturer restrictions have been implemented, has decreased by over 50% per contract pharmacy. So for every contract pharmacy that we were able to get revenue to put back into our community and our patients, we no longer have that ability. In September of 2020, Eli Lilly imposed the first restrictions on contract pharmacy, and other manufacturers have followed suit. We're now up to 29 manufacturers. One of those manufacturers, just one, Pfizer, they provide medication for growth hormone deficiency for pediatrics, metastatic colorectal cancer, breast cancer. Just that one company is responsible for blocking discounts to those life-saving medications. And it's not just life-saving medications. It's heart failure medications, diabetes, HIV, things that these patients need us to be able to have resources to provide uncompensated care to them. just today on my way here, I get called very, very frequently, 3 times on my way here today, with real patients that we take care of every day with uncompensated care. So it's critical to our mission and for us to be able to continue to offer services such as behavioral health that we're not making money, and we don't turn anyone away. We do understand that this is a federally mandated program, but we're pleading with the state to enact legislation similar to Arkansas and Louisiana, where it has made a difference, and there are manufacturers that have lifted the restrictions in those states. So we're hopeful and optimistic and appreciate support.
Thank you, Lisa. Appreciate it. And our next presenter will be Dr. Alan Jones from UMMC. While he's getting up here, I also see other representatives from Forest General. I think we have North Mississippi Medical Center. I may be missing some other folks, but speak up if I miss you. But Dr. Jones, all yours. 5 minutes.
Thank you. Thank you. I appreciate the opportunity to address you today. UMC receives 340B advantage as a DISH hospital, disproportionate share hospital, because we
Please
provide-
explain. We're on public health. Please explain
Right.
what that means.
because we provide a disproportionate share of uncompensated or undercompensated care. There are different ways that covered entities can qualify as a 340B provider. You have rural health clinics, you have HIV clinics, children's hospitals. The most common way for a health system or hospital is by providing a large amount of under or uncompensated care.
And ultimately, the DISH program is a federal program that compensates hospitals because they want hospitals to treat underinsured and uninsured patients. And so it makes up that difference. Is that a fair statement?
That is correct. So the DISH program is a way of bridging the gap between rates that are paid, let's say, for example, by Medicaid or through patients that have no insurance, to try to incentivize hospitals to care for more of those patients. So they get a supplemental payment. In the new program that was just approved through Medicaid, a lot of those DISH payments go away because UPL programs come in. But DISH is a program to incentivize hospitals to care for underserved populations. 340B is a very similar program, and as a DISH hospital, you can qualify as a 340B covered entity. We have the obligation, and we get audited by HRSA to take the revenues that we make off of this program and reinvest it into programs that spread our reach across the state. The thing that I would want to get across to you that is most important to us at UMMC about the 340B program is about the patients. If we limit the ability to use contract pharmacies to extend our 340B program, then patients suffer because of it. We see patients from 82 counties across the state of Mississippi, north to south, east to west. Those patients need a place to get those prescriptions. And if they have to drive to Jackson, Mississippi from New Albany or from Forest County or wherever it may be to get their prescription, that's an undue burden on them. A lot of them can't do it. But if they can go to their local pharmacy who we contract with and get that benefit given to them at that local place, then that is our ability to reach the patient where they are. We then take, whatever monies, revenues we make off those 340B programs, and we open new clinics. We extend our services to new areas in order to reach more patients. So at the end of the day, this is about the patient. It's not about money coming into a health system or anything else. This is beneficial to patients, and these are life-saving, life-altering medications in a lot of situations. The ability to limit our reach to patients and make patients have an undue burden to come to a central pharmacy is just unreasonable. It's not the way the program was designed. And, for as long as the program existed, when contract pharmacies came into being, this was allowed. all of a sudden in 2021 is when companies started limiting those contracts. And by doing that, it's actually causing patient harm. It's not doing in any other way, it's doing anything other than limiting a patient's access. Now, I will say you may have the logical sense of, well, why can't they just go to, let's say it's from George County. Why couldn't they just go to George County's pharmacy and get 340B pricing? Well, you can only extend to your own patients. So if you come see me at UMC and I write a prescription, that prescription is only available for 340B pricing within my 340B. You can't transfer it to another. So if I can't extend my pricing through contract pharmacies, then that patient just can't get it unless they drive to a single location. So that's why we think it's important that this legislation go through, because it benefits the patients, life-saving, life-altering treatments.
Thank you very much. And I'll just point out, you've been given a packet to the committee members, and Senator DeBar can get a packet too. I'll just point out, you have a map in there of states that are following or have done or considering doing similar legislation. And so with regards to the bill, we say this, but it actually is true in this case. This is a simple bill. If you actually look at, and starting at section 3, and by the way, section 1 and 2 is simply defining what 340B is. Section 3 is the optimum language, and simply states that with respect to 340 entities and drugs, and by the way, it's not just PBMs, it's health insurance issuer, PBMs, other third-party payer, shall not do any of the following. And it simply lists those, and in other words, what it does is simply preserve the 340B program that's there, rather than what, as it's been explained to me, is even though this program exists on the federal level, I think it's 2021, things started happening, and other states have simply put in legislation to preserve the 340B program. And so that's it in a nutshell. Now, you have before you a proposed committee substitute, and the only difference there is it removes from the original bill lines 108 to 111, right? 108 to 111, you heard some mention of an audit. I don't think it's about preserving transparency and what's in the drugs and all of that. And so that's the only difference between the committee substitute and the original. So with that, I'm going to open it up to the committee members for questions. And before I do that, I wanted to ask, I think maybe Dr. Jones can answer this for him, but my understanding is there's millions of dollars, and I know you said it's not about the money, but we're talking about this preserves do we have a number in terms of?
So I can speak to UMC because I don't, obviously have access to other people. But at UMC, for the restrictions that have been put in place between last fiscal year and this fiscal year, you're talking about $20 million in revenue that has decreased year over year because of these restrictions that have been put in place.
Okay, and so that's just UMMC. And so if you multiply that by our other hospitals, you can see, and it's no secret what we've been dealing with on our hospital. So with that, I'm going to send it.
Thank you, Mr. Chairman. And
Can
Dr.
I add one thing too? Sorry to interrupt. In terms of uncompensated care, UMMC, we average about $30 million a year of uncompensated care that we don't get any other supplemental payments for. A high of 60, probably a low of around 10 to 15, depending on the year. So we still have a substantial amount of uncompensated care that we provide even with this program.
Okay. Senator Hopkins.
Thank you, Mr. Chairman. And Dr. Jones, while you're standing there, can you be more specific about what restrictions are being placed on you? I mean, I understand the inability for patients to be able to go to a contract pharmacy. I get that, but you said restrictions placed on you. Can you
So as
give
a
me every
partner,
example?
What we do now, what we are able to do now is we are able to contract with a pharmacy in, let's say it's in Vicksburg. And through that pharmacy, we can offer our 340B pricing.
Who's putting the restriction?
purchase-
Pharmaceutical manufacturer putting restrictions saying you can't do that with
Correct. That's the whole.
that part of their contract with you for your pharmaceuticals that you sell within, that you deliver to patients there at UMMC?
Right. So the way it works is we buy the drug, we basically drop ship it to the pharmacy dispenses it, they take a fee. If we can't do that, all we can do is buy the drug and dispense it ourselves. So it's a pass-through. Our savings is a pass-through to the patient through a contract pharmacy. And what the pharmaceutical companies are doing is they're saying, we're not going to honor the 340B pricing through a contract pharmacy.
Yeah, I thought that's what you were saying. Now, the one other question I have, and this may be for Dr. Jones or you, Mr. Chairman. There was something in one of the handouts that talked about, that thwarting the drug manufacturers, from unilaterally and unlawfully changing the 340B program. Is there something in there that would, allow them to inflate prices just to reduce them? I'm trying to understand what it is. Is there a agreed upon price for every drug that is listed, or every drug that you're able to dispense
That's right. There's a 340B price
for
that
everything,
covered entity pays.
for every drug?
Or the drugs that are covered. It's not every single drug.
Okay.
Most of the drugs are specialty drugs, high-end specialty drugs. Very, very expensive drugs. And that is because otherwise patients without insurance, underserved patients wouldn't have access to those because they would have to pay out of pocket. So
Senator
it's
Hobson, if
it's
you look
certain
at
drugs.
if you look at line 17, that defines a 340B drug, and I'm looking, by the way, at the committee substitute, been subject to any offer for reduced prices by a manufacturer pursuant to 42 USC 256V purchased by the government.
So it covers pretty much every type of specialty drug that they manufacture.
Not all.
Good.
It's a robust program.
Yeah, I think that's all the questions. I may have one more, but thank you.
Senator Hickman?
I just have a couple of questions. I actually don't know who my question will be to, so whoever can answer them, that's fine with me. One of the things I often look to is what's being done in other states, and I see that there are 31 states who have either adopted or proposed programs such as what we're doing right now. Does anybody know, or can anybody speak to any impact that that's had on their program, or any way that that's affected, or have there been any negative or cons to what they've done in their states?
In Louisiana and Arkansas, the legislation has actually got the big pharma to pull back on those restrictions while they're still going through conversations about how that bill should go forward.
Thank you. And this is a federal program, correct? Does anybody know, and this may even be a rhetorical question, why the federal government hadn't stepped in and fixed these issues nationally that's going on with this program?
So the federal program, as it's authorized, is silent on the issue of contract pharmacy. And so when pharmaceutical companies began down this road in 2021, basically everybody sued everybody, and those lawsuits are still making their way through the courts. I believe that there are 3 lawsuits that are in the court system right now. One has an appellate judgment that I think has been appealed. The other 2 are unsettled at this point. So there is some federal landscape that's going on, but in the meantime, what we've seen is states have said, well, this is detrimental to our patients in our state, so we're going to step in and we're going to put the restrictions on while the federal level is working things out.
In other words, Congress hasn't done it.
Congress hasn't done anything.
That's shocking.
Absolutely. One final question, or I may have a follow-up, but this is, I think Dr. Jones can speak to this. I think you're the one that spoke to explain Senator Hobson's question. And I get an understanding that if you're allowed to use contract pharmacies, then now that is a pass-through and the benefit goes directly to the consumer or to the patient who is buying the drug. But as the program stands and as this program looks now, and I think this will still be the case, when they do purchase a prescription directly from you or a centralized pharmacy, are those savings passed to the patient the same way, or how does that work, the saving?
Savings to the patient is the same. The only difference by using a contract pharmacy is the reach. Contract pharmacy does get a fee, a dispensing fee, and they contract with us for that dispensing fee. But the savings stays in the health system, and then we're able to reinvest that savings and use it for uncompensated care. The patient, whether they come to our pharmacy or go to the local pharmacy, sees no difference.
So I guess my question is, what are these savings then that are going back? If all the, so is it just the dispersing fee that's coming back to you guys where you guys are investing? What portion of this are you guys able to invest in the system, and what exactly are you able to do with that money? Like, what are the parameters on that?
So the 340B pricing allows us to purchase a drug at a lower cost. And then we can offer that savings to any patient, right? They have commercial insurance, they have Medicare if they're uninsured. We would then bill based on our contractual rate to whatever payer it is. And there are some payers that pay full price, in which we, the health system, would make the difference between what the payer pays us and what we paid for the drug. That's where the revenue comes from. Usually it's on the commercial payer side where we make the most revenue. For Medicaid, we do not charge the 340B price. We put a modifier on that drug, and Medicaid gets the rebate. Medicaid gets the savings. We don't make anything off of Medicaid. Medicare and commercial payers are where most health systems make their money off of 340, make their revenue.
And I just want to add from our point of view, the numbers that I gave you, the 43 million, we have 31% of uninsured patients. We may not collect anything from that patient. Those revenues give us the opportunity to offset their debt, so we can continue to see them if we're not growing our business. So that's how we are reinvesting our funds, is for those sliding fee patients that we're picking up from somewhere that we have to be able to pay for them. Some of those revenues go towards that patient.
And just one follow-up, and this is just to make sure I'm getting an understanding, not really a question. So basically, the way the program works, there are certain designated entities and areas and stuff and so you have a specific price for that you are able to purchase these prescriptions at, and the patients, according to their ability to pay, or whether they are insurance and all this kind of stuff, they'll pay different prices according to that. And for your patients who have insurance coverage, you know, your patients who are fully insured and have everything they need, they can pay this higher cost, and that is what's invested back into the system. Is that kind of how that works?
The 340B pricing is to the patient, is we offer that regardless of the payer source. They get that passed through. The difference is what we bill, let's say Medicare, and what we pay for the drug. So Medicare pays us back a higher amount than we pay for that 340B price.
But that, if I understand, that price has been, is there because of this federal program?
Correct. It's a set price. That's correct. We don't set the price.
One of my patient stories or testimonies was the drug was $800 retail. Because we had 340B price and that patient paid $20. And so you think about the savings to that patient. And that was actually through a contract pharmacy.
Okay, any other questions? Senator Hill?
I guess what I want to reiterate here is we're only sitting here discussing this 340B program because the United States is the only country on the face of the earth that doesn't directly negotiate drug prices for Medicare and Medicaid. We just pay whatever they tell us to pay, while other countries are paying a fraction of what we pay, like the $20 that he mentioned for that $800 drug. And I understand why y'all have to have this, because you're in an untenable situation with the inflation of drug products. But in my research, I did learn that the Inflation Reduction Act is going to begin negotiations with certain drugs for Medicare. So it's a Band-Aid, but I understand why y'all need it.
Thank you, Mr. Chairman. Using that example, Mr. Shirley, of the $800 medication, and that you pass along the 340B price to the patient, and they pay $20 for that medicine. Let me kind of tease that out a little bit. If they're a Medicare patient, I think using what Dr. Jones said, would Medicare pay you back $25 or $30 and you take the difference? Or do they pay you back? They pay you back whatever your contract with Medicare is. What about in the private insurance? Do they pay you back the difference between 20 and 800? What your contract is with them too? And so they're all different. So your rebate, as you called it, is the amount of money you get back from either Medicare, Medicaid, or commercial insurance at all different rates.
Medicaid gets the savings. We don't, while the patient can get the 340B price benefit, Medicaid gets the savings. So we put a modifier on it to say, we offered a 340B price to this patient. Medicaid picks that up and sees it, and they get the rebate from the pharmaceutical company, not the health system.
When you say the rebate from the pharmaceutical company, are they giving you a rebate?
Savings, however you want to say it.
There's still a rebate even though the price has been reduced to $20?
Directly to Medicaid. So instead of the health system getting
I
the
need a flow chart.
revenue, Medicaid would get it. So
There's still a rebate involved from the pharmaceutical company, even though the price has gone from 800 to 20 on the price schedule.
Medicaid would get the difference of that 340B price.
Thank you. Thank you, Mr. Chairman.
I was going to mention one more thing. There's also PBMs in this, which is a totally different, kind of same concept, but a different mechanism. And PBMs can go directly contract with a pharmaceutical company to get rebates for drugs if they're on their formulary. And if PBMs don't have to comply with the same thing, then they could not honor the 340B price the same way. So you can get double hit.
Okay. And I just want to point out that, or note, because I think it's fair and the committee has a right to note. So the offer was extended to the pharmacy industry to present here, and I would just say to their credit, not that they don't care about it, they just said, we understand where things are and understand the issue and what's the question about what's happened in other states. I mean, they've recognized that. So Senator Polk, and then we do have one more bill, so this will be the last question, and we can take up the other.
Thank you, Mr. Chairman. Any of the presenters can answer this. Just to be clear, any of the rebates you get can help you pay back for uncompensated care. Is that correct?
The program actually requires us to
I
reinvest.
knew that, but I didn't know if you could go back to a debt instead of a new service or something.
You can invest it in a new service. You could invest it in expanding the service of that particular medication. You can invest it however you see fit as a health system.
But as, say, if you had $30 million of uncompensated care of individuals who receive these drugs, you could use that to pay back your uncompensated.
Yes, sir. You can offset it.
Does this have any negative effect on independent pharmacies? Because this is so complicated. I just don't know all the moving parts.
Those you whispered in my ear earlier. I have not heard that it does. And I said that was a joke, by the way. But he did point out, I said pharmacy, I meant pharmaceutical industry. And this has been public, and it's not been raised with me that this is a detriment to the pharmacy. Okay, with that, I'm going to call, do we have any motions on the table?
I move that we adopt the committee substitute.
Motion is to adopt the committee substitute. All in favor, say aye. Opposed? Okay, now we're on the committee substitute. Title sufficient, do pass committee sub. All in favor, say aye. All opposed? All right, that will be reported to Chairman Bryan and the full committee. Next, we have Senate Bill 2240 for the committee, and to briefly explain, this bill was filed by Senator Blackwell, and as you may recall, Senator Blackwell has been chair of the peer committee, and this bill is a result of a peer, investigation and report. And so it's involving the, Medical Practice Act and the, Medical Board, the Medical Board, and a little bit of the background. So as the peer report found and reported, the Medical Practice Act has not been updated since the 1980s, or it came into play in 1980, it hasn't been updated. And the bottom line is that the Medical Practice Act is not up to date with current medical practices across the country. And also, I think members of this body are familiar with complaints that they've had with the board. And so this bill is addressing what peer has stated needs to occur. And just real briefly, I'm not going to run through every section, but the main points of the bill are that it increases, updates some of the language, states who's licensed, who can be licensed. It actually, I think, expands the definition of that. It increases some of the investigatory powers of the board. Dr. Cleveland, did I see Dr. There he is. Dr. Cleveland's here from the board, and it allows for the appointment, addresses new language for appointments to the medical board by the governor. And the Board of Medical Licensure has recognized that this needed to be done, that this needed to be updated. I will state I've even in the past have filed a version of the bill. So this is bringing, for lack of a better description, bringing the Medical Practice Act into date with where things need to be, one, to be competitive, and two, for our physicians in the state. And we all know what the physician shortage that we have. And so I think this will allow us to do that, and bring that into, let's just say, the 21st century. You have before you the committee, a proposed committee substitute. The bottom line of the proposed committee substitute is that it's some cleanup language, in particular dealing with there were some typos in there that we fixed up, and so we have that. Does Dr. Cleveland, do you want to say anything on this?
Okay.
And I like that word, modernize.
Yeah, well, thank you. There are some key things. This bill strikes a bunch of antiquated language that just really doesn't need to be there anymore. And it brings us up to, 2024 type stuff, and helps us deal with some of the new technologies that are being used in medicine, both productively and for bad reasons as well in some situations. And it gives us the abilities to protect the safety of the public of Mississippi. If anybody has any specific questions, I'll be more than happy to answer them.
Wanted to point out one thing in the committee substitute, and as you know, we've done a lot through this body to bring physicians here, and the committee substitute in section 5, 167 to 177, what we're doing there, we've passed individual bills about a temporary license, and And this is simply extending, have up to 14 days for a temporary license. But actually, if you're in a program of the Office of Mississippi Physician Workforce, and you can have a temporary license up to a year, that's to incentivize those folks to be here and stay in Mississippi as we do. So with that, I think Senator Hill has a question.
Yeah, I was looking at about foreign medical license where it says that you could approve a limited license to practice medicine on lines 292. On the committee sub, yes. I think I'm on the sub. Yes, I'm on the committee sub. Lines 290 through 292, upon review of application, upon satisfaction of all requirements, they may issue a limited license. What would a limited license incur? I've never heard of a limited license to practice medicine. A limited license. It just says the board will grant a limited license from somebody from a foreign medical school upon review of their training, I guess.
I think we're talking about a limited institutional license. So a lot of times, when you have foreign medical graduates and they have trained outside the United States as well, they don't qualify for an unrestricted license. And so, at UMMC, we have, several limited institutional licenses as well as a few other, healthcare places.
Thank you.
Senator Polk.
Thank you. Dr. Cleveland, I'm a member of the peer committee, so I'm for this legislation. I think it'll help. But are we going far enough? We have so many different professions handing out prescriptions, treating patients, and they're all controlled by different boards, except I believe your board does DOs, MDs, and PAs. Is that
Podiatrist.
okay, podiatrist. Is it time to look at a comprehensive board that would encompass anyone who has the ability to write a prescription?
I think that each of us have our own special ways of looking at things. And mostly we would be talking about the Board of Medical Licensure and the Board of Nursing. And, you know, I haven't looked at it strictly from the point of view of prescriptive authority. And I can see where you would be interested in that. I just haven't had a chance to really give that a lot of thought. And I would like to think about that a little bit more before I just give you all.
I'll give you 8 minutes.
Okay.
Any other questions? To Senator Hobson's question, he pointed out into Senator Hill's question, wherever it was the temporary institutional license. So, unless there's objection from the committee, would ask that the technical amendment be made to conform to that language. Is that acceptable? Any objections to that? So with that, you have motions on the table, or any other questions? I don't see any other questions. You have a motion on the table?
Move that we adopt the committee substitute.
The motion is adopt the committee substitute. All in favor, say aye. Opposed? Carries. Now we're on the committee substitute itself. All in favor, say aye. All opposed? Okay, that carries. And with that, I thank the subcommittee, and we'll report this on the final motion to the full committee. Motion's rise and report. Thank you.